hosting the second plenary. Ladies and gentlemen, our third plenary is up next. I cordially invite Dr. Niyomali Amarasena, past president of the Ceylon College of Physicians and consultant cardiologist, and Dr. Tanya Pereira, president, Sri Lanka Heart Association and consultant cardiologist, Cardiology Unit, National Hospital of Sri Lanka, on stage.
Good morning, a very good morning to all of you here. Our next speaker for the plenary Syncope of Physicians is Dr. Mevan Wijethunge. He actually needs no introduction to this audience because he has been a speaker for many sessions of ours. Dr. Wijethunge is a cardiac electrophysiologist. He is medical director of the Heart and Vascular Services at Altru Health System in North Dakota, USA. Dr. Wijethunge is an American board certified physician in internal medicine, cardiovascular medicine, and cardiac electrophysiology. He is the governor of the North Dakota chapter of the American College of Cardiology. Dr. Wijethunge is a local graduate. He attended the University of Colombo and completed his medical education at Uppsala University in Sweden. He underwent residency in internal medicine at the University of Hawaii and fellowship in cardiology and cardiac electrophysiology at Georgetown University in Washington, D.C. Dr. Wijethunge has published over 30 articles in medical journals and has been an invited speaker at national and international conferences. He has been selected among the best instructors in medical education at the University of North Dakota School of Medicine. Over to you, Dr. Mevan Wijethunge, for this plenary.
Thank you so much for that kind introduction. When I was assigned this topic by my friend and the president of the CCP, Dr. Upul, I asked him to give me some guidelines. He said, we have strict guidelines. Most importantly, Dr. Upul should not fall asleep during this talk. And I certainly try not to make him syncopal. So what I'm trying to do is to give you two clinical scenarios and then try to work that through and to get some direction on how to manage syncope in the broad setting. Let's go on quickly with the time intervals. We have a 70-year-old professional singer, actually a friend of mine, Sri Lankan, with a history of diabetes and hypertension. He was on losartan, metformin, and atorvastatin. He had a syncopal event at home while talking to a friend. He felt nauseated, warm, but no chest pain, shortness of breath, palpitations, or deja vu. So the family insisted, and then they found the patient to be clammy and cold. And the episode lasted for a minute, and the wife saw there was some limb twitching, few seconds. He woke up well, but reported feeling tired, and he was okay. So that's the clinical scenario one. And the scenario number two is an 18-year-old student, in this case a girl, with no previously known medical conditions, and she was an athlete, and she was participating in a 4x400 relay and had a syncopal event on track, witnessed, and woke up, but again, she didn't have any preceding chest pain, shortness of breath, palpitations, or deja vu, and she woke up well after the event. So two scenarios. And let's go on. So initial evaluation, this is mostly, I took this based upon the European Society of Cardiology guidelines. My talk will be based on that and with a mixture of American College of Cardiology, but mostly ESC. So the initial evaluation of syncope is to determine whether the patient had what we call a transient loss of consciousness, or TLOC. And what constitutes TLOC is there should be an amnesia for the period of unconsciousness, and there is a loss of responsiveness that during that time, and maybe accompanied with some sort of an abnormal motor control, short duration, because if the loss of consciousness prolonged, we start thinking of more deeper state. And then we have to, first of all, very easily figure out whether it's a traumatic loss of consciousness or was there any head trauma involved preceding that? Because that's, not then it goes to a different realm. And in either case, we know there's no trauma, and we know it's TLOC. Then thing is, okay, the patient lost consciousness, and is it syncope or non-syncope? So what is syncope? Look at this. This is King's birthday, got from internet. And you see another person being taken out on a stretcher. And this gentleman was quite robust. He stood up, tried to play, but was not allowed. He was taken away. So, syncope is transient loss of consciousness. This is the definition, due to cerebral hypoperfusion. It's characterized by rapid onset, short duration, and spontaneous and complete recovery. And that was the meaning of the preceding video. There was spontaneous recovery to the level that the gentleman stood up and wanted to continue to play. And that's the important, because if you don't spontaneously recover, or without, that means spontaneous, no intervention. So that's one of the revealing points for me in this definition is that the olden days when we studied, we put hypoglycemia as a cause of syncope. No longer that is a part, because in hypoglycemia, you don't recover spontaneously. So the metabolic causes are not included anymore. You need to intervene in those cases. So transient loss of consciousness, and it involves cerebral hypoperfusion. That's the key. Of course, the patient doesn't tell you that I had cerebral hypoperfusion. You need to figure that out. And rapid onset, short duration, and spontaneous and complete recovery. Those are the definitions. So when you have transient loss of consciousness, syncope constitute one category. Under that category, you get a reflex syncope, orthostatic hypotension, and cardiac syncope. Then there are other non-syncopal reasons like epileptic seizure, part of things to rule out, or psychogenic, and the rare causes like vertebrobacillar TIAs and subarachnoid hemorrhage. And those are non-syncopal reasons of transient loss of consciousness. So in our questionnaire, both patients had transient loss of consciousness. And is it syncope or non-syncope? It's likely syncope. Then you are suspecting syncope, what's the etiology? So syncope by definition is a decreased cerebral perfusion, right? That's a core, that is the ultimate common pathway. And as we all learn in physiology, cerebral perfusion, the blood pressure cerebral perfusion is dependent on, it's a simple formula of cardiac output times heart rate. Peripheral resistance. And cardiac output in turn is determined by stroke volume and heart rate. So anything that lowers your peripheral resistance, it could be drugs, it could be autonomic nervous system problems, can cause it. Also, a low cardiac output due to inadequate venous return or any cardiac problems. And first most important thing is reflex problems that can either cause lowering peripheral vascular resistance or cardiac output. So these reflex causes can predominantly either depress your blood pressure called vasodepressor or decrease your heart rate called cardioinhibitory or mixed type. And low peripheral resistance, as you know, could be due to primary or secondary autonomic nervous system problems, or venous return. It could be that you had a bleeding or volume depletion or venous pooling. And cardiac causes, which are considered very serious, could be due to an arrhythmia or structural heart disease, a valvular heart disease, aortic stenosis, or other causes including pulmonary embolism. So in a patient with syncope, the single most important to think about is what the patient tells you, the history. And history probably can help you to alleviate address 90% of cases. And then physical exam, including supine and standing blood pressure and an ECG. That's the basic investigation every syncope patient should undergo. And beyond this, you can tailor-make to the patient's story. So when it comes to reflex syncope, this is something most of us have experienced in a minor or major form during lifetime. It's a reflex, and I'm not going into details, but the Bezold-Jarisch reflex that we talked about in the medical school appears in an exaggerated manner to cause bradycardia or hypotension, and it's a reflex, so it's a momentary thing. And in reflex syncope, there's a certain pattern if you find this in the history. These are like recurrent syncope in younger patients, and and can occur after unpleasant sight, sound, smell, or pain. It could be a bad news that make you pass out, or prolonged standing, like in the case we saw in the video. This can happen during meal. A vagal reaction can get precipitated by that. In hot and crowded places, church or religious places are quite common in this regard, and can be accompanied by this pale, sweating, nausea, vomiting. So imagine that your spouse falls to the ground and look pale and eyes rolling up. That's a very horrifying sight for the family, but all the patient had was a reflex syncopal event. And this could be triggered by head rotation. You're having a tight neck collar, pressing the pressure on carotid sinus. Or it could be induced by coughing, particularly if you have COPD, or sometimes during micturition and deification. Not every time you pass stools, but it can trigger the thing. And these reflex syncope patients often tend to have heart disease, at least you need to rule out. Orthostatic hypotension, on the other hand, obviously, it's while or after standing, or prolonged standing, or standing after exertion, after a meal, and then you look into the medications and see whether there's anything there. And the patient has a history of autonomic neuropathy, diabetes, and so on. The traditional or standard definition of orthostatic hypotension is a systolic blood pressure drop of 20 millimeters of mercury or greater, or diastolic drop of greater than 10, or absolute systolic blood pressure of 90 with symptoms. Cardiac syncope, which is something we have to be very vigilant about. If the patient gives a history of syncope during exertion or when supine, okay, exertional syncope is a key factor here. Now, you can have vasovagal syncope with exertion, but just don't dismiss it right from the get-go. If the syncope is preceded by palpitations, and then you get syncopal, or the patient has a family history of unexplained sudden death, or the patient has already pre-existing structural or coronary heart disease, then you take it seriously. Or the patient has abnormal physical exam related to the cardiovascular exam or ECG. And then based on the initial findings, you can do whatever the test you need to, heart monitoring, echo, perform carotid sinus massage if you suspect that, and then depending on the scenario, if the pulmonary embolism, you go with blood gas or bleeding hemoglobin and so on. And then you can consider head-up tiltable testing to confirm your suspicion if you're thinking of vasovagal syncope. But those are additional testing, but nothing replaces history, physical exam, and basic ECG. So these patients, yes, we know it's TLOC, likely syncopal. And in the first patient, it sounds like reflex syncope. In the second patient, the young girl, it does not sound like that. So, question to us is not the syncopal event, because both patients are in front of you, looking good, vital signs are good, talking well, breathing. They don't have any symptoms to complain about. But the problem is there a risk of worse outcome prognosis, which everybody is worried about, is cardiovascular events or death. How do you risk stratify these patients? And that's often the question. So it's our job to see whether it's a low-risk event. The low-risk events are if the patients have a prodromal symptoms, such as preceding nausea, vomiting, a blurry vision, muffled hearing. This sounds more like a vasovagal. And then if it happens after prolonged standing, sounds more like orthostasis or vasovagal. Hot crowded places we talk about during or after a meal, because the splanchnic circulation is pulled in blood, relative volume depletion to the heart, or triggered by cough, urination, and passing stool. Sounds more like reflex. Head rotation or pressure on carotid sinus. So, we have case reports, even patients syncopal after exercise, but then you figure out that they check their pulse, pressing on the carotid, and that's the time they become syncopal. And also change of posture. So these features suggest the patients have low risk, because this is important to tell the patient. And in the exam, if the low risk patients, you often have many years of recurrent syncope. If it's that bad, they should be gone by now. Or other thing is they have no risk history of heart disease, and the exam is normal. So in the case 1, I would call it They are low risk features and reflect syncope. Remember, this is an elderly kind of a gentleman, nationally well-known person. You have to take a stance and say, look here, you're not going to die from that. So handle that scenario because based on the clinical history. All right. So high-risk syncopal events, on the other hand, something you need to put weight on. If has new onset dyspnea, chest or abdominal pain or headache associated with this, or if it occurred during exertion or supine, and if there's palpitation, suggests there's an arrhythmia. And as mentioned, if the patient already has structural or coronary heart disease like heart failure, low left ventricular ejection fraction, prior myocardial infarction, always take it seriously. Undiagnosed systolic murmurs or abnormal ECG. So, a simple mnemonic to know abnormal ECG is A, B, C, D, E, left, right. A is for AV block, B is for Brugada, C for QT, spelling, C-U-T-I-E, QT prolongation, D for delta wave, E for epsilon wave, L for left ventricular hypertrophy, R for right ventricular strain. So I just quickly go through these ECGs, A, B, C, D, left, right, and AV block. I mean, even this is third degree AV block, complete heart block, but it doesn't have to be. It can be even anything you're suspecting, any degree of conduction abnormality. Put a little bit weight on that. That sort of increases the risk. Obviously, third degree AV block is serious. And then you see the P waves marching through and separated from QRS. The Brugada type ECG pattern is, I think most of my colleagues here have seen this. It's not uncommon in our setting. And patient could be entirely asymptomatic, obviously had one syncopal event. If you see this, immediate referral to cardiology and electrophysiology is warranted because nocturnal sudden death is associated with this condition and mostly young males. These are rare, but can be devastating. And QT prolongation, whatever the reason, it could be young or old, and you find this, please be vigilant because the QT interval is something we tend not to look into in an ECG commonly, but it doesn't hurt to look at it and looks long, do some measurements and see what is there, right? Is it a drug induced or is it a family history, whatnot, but don't wait too long. That's C, QT. And D for delta wave, I think I had ECG discussions and everybody recognizes them, the slurred upstroke or downstroke and with a short PR interval. So because these patients can develop atrial fibrillation and have rapid conduction and get this very rapidly conducted ventricular pre-excitation, and this in turn can trigger ventricular arrhythmia and death. Rare, but entirely preventable if properly detected. Because this is a cause of sudden death in otherwise entirely normal hearts in young people. So E for epsilon waves, again, this is a notch that you find at the end of QRS complex. This is because people with right ventricular hypertrophy, right ventricular cardiomyopathy, they have scar tissue in the right ventricle and that causes this delayed conduction, causes this, you need to zoom in to see this in lead V1. And left ventricular hypertrophy, particularly in the setting of, I think, what happened here? Yeah. Let me see if I can advance my slides. It suddenly stopped working. But it does. Yeah. So left ventricular hypertrophy, because hypertrophic cardiomyopathy and syncope, they are very not uncommon and can be this can lead to sudden death. The other one, because this is an example, a patient with a hypertrophic cardiomyopathy we have implanted a defibrillator and obviously he was saved from a ventricular tachycardia, ventricular fibrillation type of an arrest, and you can see a shock was delivered at the red arrow and it's entirely a preventable death. But the important part is finding these patients. They are rare and few and risk stratification. But that's up to usually cardiology to do that. In the primary care setting, the key here is unusual form of syncope and abnormal ECG. And arrhythmogenic cardiomyopathy, usually you have signs of right ventricular strain, which is usually T-wave inversions across the precordial leads, and you see these T-wave inversions which are abnormal. Now, people might think that's ischemia, but in the right setting, no chest pain, nothing, had a syncopal event, and this is something. And because these patients too can get this, sometimes in extreme cases, this dilated right ventricle, which is very hypokinetic, and they are very prone to a ventricular arrhythmia event. So, in the case number 2, a young girl who passed out during exercise, that feature itself warrants further look. ECG could be normal or could have some clues, but that kind of a situation warrants further investigation, because that could be, because anything that carries a bad prognosis in a patient like that will be usually newspaper headlines, because this young healthy girl dies on the track, which is very emotion-provoking. Not only that, but also preventable. So that's a patient had high-risk features, and you can question whether the patient had cardiac syncope. So I was concerned and that after me there will be an oration. I certainly didn't want to exceed my time. I think my personal record, I even finished 5 minutes before the allocated time. Thank you for your attention.
Dr. Mevan Wijethunge, we thank you for that very insightful and educative lecture on actually a very common topic. We must also congratulate you for finishing 5 minutes before time. I would now like to call upon Dr. Niyomali Amarasena, who is the former president of the Ceylon College of Physicians, to hand you our token of appreciation.